Hello, everyone. Thank you so much for your patience. We just had a bit of technical difficulties. Wouldn't be like me on my first webinar. So I just want to say thanks so much for all of your patience, and I really appreciate you all coming here and joining me today for such an important discussion. So I'm joined by Diane Danzebrink. We've been working closely together to normalize discussing menopause supports for women in the workplace. Diane has found extensive knowledge and experience only through her own struggles when herself was going through menopause and found lack of education information. So she has started this amazing campaign and is very happy to have our keynote speaker today to discuss this with all of you, to normalize this conversation, how you can get support for yourself if you're going through menopause, or if your colleague, your family member, or anyone else is going through it and you want to know how you can better support them. So thank you so much for joining me again, and I won't take up much more of your time, and I'll hand you over to Diane Danzebrink. Thank you so much.
Thanks, Chelsea. Thanks so much for inviting me. Hi, everybody. Apologies for the technical glitch there. So, as Chelsea said, I'm Diane Danzebrink. I'm your host for this afternoon's session, and we're going to be talking about understanding menopause. So whether you're going through it personally or whether you are going to be supporting somebody who's going through menopause. So I thought we would start with a little introduction to me. As Chelsea said, my sort of original initiation, if you like, into the world of menopause was a personal one. I went into a surgical menopause about 10 years ago, had very little professional support and guidance. And my own experience led me really to ask if there were other people who were struggling with a lack of information prior to menopause coming along. So my background is in therapy. I work mainly now as a consultant to individuals and also to businesses and organizations. My special interest, obviously, is in menopause and in mental health. I have professional nurse training in menopause. I'm a member of our National Menopause Society. I'm the founder of menopausesupport.co.uk, which is a small not-for-profit organisation, and also of the national Make Menopause Matter campaign. And Chelsea mentioned the campaign to you. The campaign is a national campaign. It's really looking to improve menopause care and support for everybody. So we have some very key aims around medical healthcare professional education, so particularly for our GPs and our medical students. Education at an early age, so having menopause included in the curriculum in schools alongside periods and pregnancy. To have menopause guidance and support for everybody in the workplace, and for the sitting government to create a national public health campaign for menopause to educate and inform everybody, hopefully, before it comes along. So why is menopause important? Why does it matter? Well, approximately half of the world's just over 8 billion population will experience menopause directly. The other half are very likely to be related to, friends with, or colleagues with somebody who is going through it. So there's probably not anybody on the planet who is going to go throughout their lifetime without experiencing menopause themselves, or in fact knowing somebody who does. Menopause can have varying impacts. For some people, it will be on their physical health and well-being, for others on their mental health and well-being, but it could also be on wider aspects of their lives, things like their relationships, their careers, even down to their finances. Now, we know as far as the workplace is concerned that we have just under 5 million women over the age of 50 currently in the workplace. It's the highest number ever, and it's the fastest growing demographic. So menopause and postmenopause are going to be things that are happening to individuals in the workplace more and more in the future. And that's another reason why it's so important that we know how to support. And essentially, having more education and information allows those people who are going to experience menopause themselves feel more informed about it, but it also allows those who are going to be in supporting roles be a little more understanding and compassionate. So, of all of those who are going to experience menopause directly, approximately 3 out of 4 will experience symptoms. 1 in 4 will have very few or no symptoms at all, and 1 in 4 will describe their symptoms as debilitating, so significantly affecting quality of life. It's a very, very individual transition. So, as I say, some people will barely notice menopause until they know that their periods have stopped. For other people, it will have significant impacts, and those impacts can last for different lengths of time. I mentioned the British Menopause Society to you at the beginning of the presentation, and I also mentioned the varying aspects of menopause. And every few years, the BMS do a survey. The most recent one focused on personal relationships. 51% of respondents who will have perimenopause, menopause, etc., they said that their intimacy was significantly affected. So their intimacy with their partner. 38% of partners said they had no idea how to support somebody experiencing menopause, and 28% said that looking back, they recognised that it had caused arguments. So as I say, the effects can be wide-ranging. Now, menopause awareness has grown significantly in the last couple of years. I've been sort of raising awareness and campaigning, etc., since around 2015. But in the last couple of years, we've seen more and more well-known faces speaking about their menopause experiences. And awareness raising is great, but we also need to have an infrastructure available so that when people do need help and support, they can get that. So what is menopause? Well, it can be a little bit confusing because the menopause transition can last for several years for some people. So it really falls into 3 sort of areas. The first of those is perimenopause. So peri meaning around the time of. So perimenopause is essentially the time in an individual's life when the egg store that we have in the ovaries is starting to run out. That's having an effect on the hormones. So we have estrogen and progesterone rising and falling every month. As the egg store starts to deplete, those hormone levels become more erratic. And when they become more erratic, for those who will experience symptoms, that's why the symptoms begin. Now, for many people, perimenopause will begin in their early to mid 40s. Almost everyone will be perimenopausal by the time they're 45. And perimenopause can last anything from several months to several years, depending on the individual. So for many, the perimenopause to postmenopause transition can be 7 or 8 years. So menopause is the word that we use as an umbrella term to cover the entire transition, but it also has its own clinical diagnosis. And the clinical diagnosis of menopause is actually retrospective. So you only know that you are menopausal once you've had 12 continuous months without a period. And then postmenopause is the years after those 12 months consecutively without a period. And as I say, that entire transition from the beginning of perimenopause to postmenopause can last several years. So the average age for people experiencing menopause, so the 12 continuous months without a period, is regularly between the ages of around 51 and 52. Most people will have stopped having periods by the time they're 55. So menopause usually happens anywhere between the ages of 45 and 55. It can happen a little bit later. It's unusual, but it can happen. But it's also important to know that it can happen earlier too. And earlier is, so an early menopause would be somebody who experienced that total cessation of periods between the ages of 40 and 45. Premature menopause would be those individuals who experience that total cessation of periods under the age of 40. And currently in the UK, we know that around 1 in 100 under 40, 1 in 1,000 under 30, and 1 in 10,000 under the age of 20 will experience a premature menopause. And there are lots of potential reasons why somebody would experience an early or premature menopause. So premature ovarian insufficiency is a diagnosis where somebody's ovarian function is not as doctors would usually expect it to be. So the ovaries are not functioning in the way that doctors would usually expect them to. For those individuals diagnosed with premature ovarian insufficiency, a lot of them never really get a complete diagnosis because for many of them, they're told that their diagnosis is what doctors describe as idiopathic. And essentially that means we don't really understand why this has happened. There are other reasons why somebody might go into an early or premature menopause, and they could be a bilateral oophorectomy, which is essentially when somebody goes into surgical menopause. That's having both of their ovaries removed at the same time. So that means the ability to produce estrogen and progesterone is significantly reduced. If somebody has a hysterectomy, so that's having the womb removed, even that surgery can mean that somebody can have a slightly earlier menopause than they might have had if they hadn't have had the surgery. And then there's what's called medical or induced menopause. So a medical or induced menopause is where the ovarian function is changed for some reason. So that could potentially be chemotherapy or radiotherapy that has an effect on the ovaries. Or it could be that somebody is having a type of medication to help them with another medical diagnosis. So if somebody has something like endometriosis very severely, or if they have a condition called PMDD, which is premenstrual dysphoric disorder. So that's a very, very severe reaction to an individual's own monthly changing hormone levels. If they have either of those conditions, they might have a medication which again can essentially shut down the ovarian function. And all of those things can potentially bring on menopause symptoms. So there are rarer conditions too, which can bring on an early menopause, but it's also useful to know your own family history and whether or not you have a mother, sisters, grandmother, etc., who experienced an early or premature menopause. It doesn't necessarily follow that you will go down that path, but we do see some cases of family history. So in summary, menopause can be natural, can be surgical, where the ovaries are removed, can be medical, where the ovarian function is suppressed with either medical treatment or medication, can be premature under the age of 40, and can be early under the age of 45. So I've mentioned the hormones a couple of times, so I thought it would be useful to explain what they do, because that then helps us to understand why those symptoms begin. So estrogen has a role to play in the monthly menstrual cycle. It's also very much a nourisher and a lubricant of the body tissue. So we have estrogen receptors all throughout the body, from the top of the head to the tip of the toes. Estrogen is key in maintaining bone strength, in helping with things like heart health, with our internal temperature, so the internal thermostat, and it also helps to regulate cholesterol levels. So when those hormone levels start to fluctuate more regularly and sometimes more significantly, that makes sense as to why the symptoms can be quite varied. And then progesterone. So progesterone too has a role in the monthly cycle. It also helps to sustain a pregnancy. And for some people, progesterone can act as a mood calmer and also help to promote their sleep. It's not fair to say that for everybody because some people are more sensitive to their own changing hormone levels than others, but for some, that certainly is the case. And then testosterone. So you might be surprised to see testosterone included here. Testosterone is often incorrectly described as a male hormone. Testosterone is a hormone that is more predominant in males than it is in females, but it does occur in females too. Currently, the research around testosterone is very much in relation to libido, but we also know, certainly anecdotally, that those who have supplemental testosterone find it useful for other things. But unfortunately, we don't have good, strong data currently to support that. So what's happening to those hormones during perimenopause? Well, the purple line there represents progesterone and the red line represents estrogen. So during the perimenopause to postmenopause phase, progesterone falls quite rapidly and then estrogen starts to fluctuate more regularly. So you will often hear people say things like that they feel better one day than another, or they feel better in the morning and can't understand why they don't feel so good in the afternoon. And that's because those estrogen levels can change not just on a daily, but on an hourly basis during that perimenopausal transition. Now, as I said, for some people, they will barely notice those changes at all, but for others, symptoms can be significant for them. And when we're looking at symptoms, I think everybody probably has heard of hot flushes and night sweats, and probably everybody is familiar with menopause and the ending of periods. But symptoms are more complex. So symptoms really fall into three categories. We have the physical, the cognitive, and the psychological symptoms. So the physical symptoms, as I said, everybody's heard of hot flushes and night sweats and periods changing. But then there are also things like heart palpitations, achy joints and muscles, perhaps dry, itchy skin, changes to hair where hair can thin and dry eyes, dry mouth, perhaps things like changes to gut and bowel health, because as I said, estrogen has a part to play almost everywhere in the body. And then some of the symptoms that people might find it very difficult to talk about. So things like increased urinary frequency or urgency, urinary tract infections, and vulval and vaginal symptoms. Estrogen has a significant part to play in the pelvic area. So when things start to change, consequently, symptoms can occur that perhaps people wouldn't necessarily relate to perimenopause. Then the cognitive symptoms, which are generally under the umbrella term of brain fog, really mean changes to memory and concentration. And that can be troubling at any time, but particularly in a workplace environment. And then with the psychological symptoms, the most common one that we see are things like anxiety, low mood, mood changes, and also changes to levels of confidence. And again, difficult in a home environment, but certainly challenging in a workplace environment. So, potential impacts of symptoms can be physical, cognitive, or psychological. For some people, they will be a mixture of all three. For others, they won't experience any of those symptoms whatsoever. So the potential impacts of symptoms, well, as I said, they can be wide ranging. So it can be on our relationships. So that could be our relationships with our family or our friendships, with our colleagues, And on our social life too, you know, if your main symptom is lack of energy and feeling very tired, then it can be difficult to maintain a social life, particularly if you're in the workplace too. There's also other potential challenges to consider, and they're things like cultural challenges and also the challenges of things like neurodiversity or hormone sensitivity. So in some cultures, we know that there is no word for menopause. So it's incredibly difficult to talk about something, even within your own friendship group, where there is no word for it, and you're certainly not encouraged to talk about it. Having a lack of information about menopause can make it very difficult to make informed choices. Finding it difficult because of the embarrassment that you might feel around it, and having a lack of support. And then we also have to think about, for those who have hormone sensitivity, so it could be severe PMT, or as I mentioned, PMDD. For those who've experienced postnatal depression, we know that those things are related to hormone levels. So really important, if that resonates with you, as you approach perimenopause, to make your healthcare professional aware of that. And then also neurodiversity. So we know that some of those with diagnoses like autism and ADHD, we're seeing the very early stages of research showing that as individuals go into their perimenopausal stage, the changing hormone levels can increase the challenges that those individuals face. So there's a lot more work to be done on that, but it's useful to know that, again, if that's you, or if that's somebody that you know, or somebody that you support in the workplace. So some of the key things, and remember, I'm talking here about the people who really struggle with their symptoms. So we're not talking about everybody, but some of the key things that we hear as a support organisation on a very regular basis are, I feel like I'm going mad. So people don't recognise that there could be psychological symptoms associated with menopause. I've even had people say to me, do you know, I think I might have early onset dementia, because they had no idea about the effects of estrogen. I feel so alone. It can feel like a very lonely place, particularly if your friendship group are not experiencing perimenopause yet, or in fact, if they're reluctant to talk about it. And this is another place where the workplace can be so useful, because if you're not talking about it socially, being able to access not just information, but also support can make a huge difference to somebody's life. I've lost my joy. I don't really feel like me anymore. And the relief of having somebody to talk to who understands. And I think it's really important to stress that that doesn't have to be an expert. That can just be somebody with a good working knowledge of what menopause is, when it happens, why it happens, and most importantly, signposting and support can make an enormous difference in somebody's life. So how is menopause diagnosed? Well, this is a regular question. And we hear of lots of people who are incorrectly offered blood tests over the age of 45 to diagnose perimenopause. So in the UK, we have very clear NICE guidance. So NICE is our national institute. And they issue guidance not just for our medical health professionals, but also for the public too. And they're very clear that over the age of 45, blood tests for perimenopause should not be offered. And as I said right at the beginning of the presentation, we expect almost everybody to be perimenopausal by the time they're 45. So cast your mind back to that wiggly purple line on my graph, and those hormone levels are going to be fluctuating on a very regular basis. So a blood test tells us nothing. What we need to have a conversation with the patient to find out what they're experiencing. If somebody is between the ages of 40 and 45, a blood test may be appropriate. But again, if perimenopausal symptoms are very clear, then it might not be required. If somebody is under the age of 40, it's vital that they have 2 blood tests 4 to 6 weeks apart. That will give the initial diagnosis for a premature menopause, and then it's highly likely that that person should be referred into a menopause specialist clinic for specialist care. So as far as symptoms are concerned, as I said, 1 in 4 will experience almost no symptoms at all, but 3 out of 4 will experience symptoms. So what are the management options? Well, again, NICE guidance is very clear. The first line treatment for menopause is HRT, or hormone replacement therapy. Now, that should be based on an individual consultation and also on patient choice. So many people will choose to try HRT, some will choose that it's not for them. But if you do decide that HRT is for you and there's no medical reason why you can't try, if you still have your womb, when you have estrogen, you must have progesterone too. So progesterone can be in a combined patch with estrogen. It can be a separate oral prescription, or if you have the Mirena coil already for heavy periods or contraceptive purposes, if it's within its 5-year license, you can continue with the Mirena coil and just add in some estrogen. So that'll be your estrogen and progesterone combined. If you're somebody who's had their womb removed, so if you've had a hysterectomy, potentially you can just have estrogen, unless you've had your hysterectomy because of very severe endometriosis. If that's the case, it's appropriate, at least initially, to have progesterone too. How you have HRT is not just dependent on whether or not you have your womb, it's also dependent on, for those who still have their womb, whether or not they're still having periods. So if you're still having monthly periods, then you should have a sequential type of HRT. So that's estrogen every day and then progesterone for just part of the month. If you're somebody who's stopped having periods, then you can have a continuous type of HRT, which is estrogen and progesterone every day. It used to be that all HRT was oral, so taken via the mouth. However, now there are also transdermal preparations. There's an estrogen gel, patch, or spray. There's a combined estrogen and progesterone patch. So if you're having an estrogen gel, patch, or spray, and you're not going to have the combined patch, and you still have your womb, you will need to have a separate progesterone alongside that. Testosterone, for some people, they will benefit from additional testosterone too. So particularly those in a premature or surgical menopause where ovaries have been removed, because we make a certain amount of testosterone in the ovaries, particularly those individuals, it's really important for them. But even some people in a natural menopause will find that testosterone can be useful too. Again, it's all very individualized. So the main benefits of hormone replacement therapy, as I said, it's the first line treatment to improve symptoms. It can help to reduce the risk of osteoporosis and heart disease, that's in long-term health. For those who are under the age of 45, it's really important that if there isn't a medical reason why they can't replace hormones, that they should do so at least until the natural age of menopause, so around 51, 52. And it's really important to remember that it's all about having the right HRT in the right individual. And with those things in place, the British Menopause Society are clear that currently overall benefits outweigh any small risks. So at the moment, benefits outweigh any risks. If you choose not to have HRT, or for some reason, because of your medical history, you can't have it, there are other options available. So there are other medications which are non-hormonal medications that can be offered. If somebody has had a hormone receptive cancer, then that's often a reason why HRT is not offered. There is a new treatment coming specifically for those individuals. It's probably still about 18 months, 2 years away. It's in the last stages of research and trialing, but there is something else on the way. I mentioned when I was talking about symptoms, things like the genitourinary symptoms, so the increased urinary frequency or urgency, and the vulval and vaginal symptoms. We often speak to women whose mothers, so women in their 70s and 80s, are experiencing these symptoms and have for many, many years, and unfortunately have never related them to menopause, to that reducing level of estrogen. So there are local treatments that are available. They're usually called vaginal, local, or topical estrogens. And topical estrogens are very, very low doses, and they're applied to the vulva or vaginally. And they can be things like a cream, a pessary, a vaginal ring, or a gel. They can be incredibly helpful for not just those in perimenopause, but also postmenopausally too. And particularly for older women who perhaps have never had HRT or it's not an option for them, they can certainly have those local estrogens to ease those vulval, vaginal, and urinary symptoms. For some health areas, doctors can give talking therapy options, but it's very postcode lottery. And if you're somebody who has a significant medical history, so if you're somebody who perhaps you have a complexity in your medical history and your GP doesn't feel that they can manage your menopause care, you can be referred into an NHS menopause clinic. Now, we don't have them in every county in the UK, but we do have access to them. Unfortunately, as you know, with many NHS waiting lists, they're long, but you would see a British Menopause Society recognised menopause specialist. So it's certainly worth asking to be referred. There are also lots of things that we can do for ourselves. So things like looking at our nutrition, at our exercise, at our stress levels, because they can all have an effect on our hormones and how our symptoms are exacerbated. So we know that taking regular exercise is not just good for our physical health, but our mental health too. We know that a healthy diet can help support us, but we also know that there are some things that can exacerbate symptoms that you're already having. So things like alcohol, fizzy drinks, spicy food, caffeine, and lots of sugar can exacerbate symptoms. So looking at not necessarily cutting all those things out, but maybe reducing them can also help you to help yourself. There are an absolute plethora of alternatives now. One of the downsides of raising menopause awareness has been the amount of products which have become available in the last few years, and it's quite overwhelming. But there are some popular options which have been popular long term. So things like sage, red clover, black cohosh, St. John's wort, omega-7 and omega-3, and for some people they find magnesium is helpful for their sleep and things like if they have restless legs. If you're already on any prescribed medication, before you add anything in, please always check either with your doctor, your practice nurse, or your pharmacist to check that there aren't going to be any contraindications. And I will often point people in the direction of the National Institute of Medical Herbalists if they're looking to manage their menopause symptoms with supplements, purely because for a one-off consultation, you will see somebody who is medically trained and a herbal expert, and often it can be more cost effective than trying to pick something off of the shelf for yourself. Lots of complementary options too. A lot of people find things like mindfulness, meditation, yoga, Pilates, reflexology, talking therapy really helpful for them at this time in their life. But ultimately, it comes down to, as I said, it is very individual. So ultimately, it's really about whatever works best for you. So if you're thinking of heading off to see your doctor, just a couple of key points from the NICE guidance. If you're going to see your doctor, it's important that that is a consultation where your doctor talks to you about optimizing lifestyle, options for symptom management, and also looking at your long-term health, looking at all of the options that are available and not giving you a blood test if you're over the age of 45. They shouldn't be saying that they don't prescribe particular things. If they're on the formulary, then they're available to be prescribed. And they shouldn't be saying, particularly with HRT, that you can have it for 2 years or 5 years. Actually, there is no defined timeline for how long an individual can have HRT. There should be an annual appraisal. And once you've had your first prescription, that should be for 3 months. And then there should be a checkup appointment at 3 months. So if you're preparing, ideally, if you can, I know it's difficult even to get an appointment at the moment, but if you can, try to book a double appointment. Ask to see either the GP or the nurse in the practice who specialise, if not in menopause, in women's health. Know what the NICE guidance says. Fill in a symptom checker. You'll find one on the Menopause Support website. Keep a diary of your cycle if you're still having one. And they're all things that you can do to essentially get the best out of your short appointment. They're usually around 8 to 10 minutes, but if you can get a double appointment, then it can be really helpful. So as I'm talking to you in your workplace, I thought it was important to look specifically in this introduction to menopause at work, and it is very much an introduction. But some of you will have heard of the Chartered Institute of Personnel and Development. They have an excellent menopause hub on their website with lots of really useful information. But they also did the most wide-ranging and in-depth survey on menopause in the workplace back in 2019. And as you can see there, 59% of respondents said that symptoms had a negative impact on them at work. 65% said that they found it more difficult to concentrate, and 30% of respondents said they'd taken sick leave. Now, there were varying reasons why they chose not to disclose. So 45% said privacy, and everybody is entitled to that. 34% said because they felt too embarrassed to talk to their line manager about it. And 32% said they felt that their line manager would be unsupportive. Now, we're certainly making strides in supporting menopause in the workplace, but I think that shows us how much work there really is to do nationally. So some of the most common symptoms that people reported were those hot flushes, sleep disturbance, which can really have an effect on every part of our day. If we've had several nights without good sleep, then that can have a significant effect on both physical and mental health. Night sweats, which again interrupt our sleep, and those psychological symptoms that I talked to you about, anxiety, mood changes, etc. So that's the CIPD hub, if anybody wants to have a look at it. It's called Let's Talk Menopause, and it's got some great information on there. So if you are in the workplace and you're in a position where you need to seek support, or in fact, you're in a supporting role, what can you do? So let's look first at seeking support. if you're somebody who thinks, okay, I'm having these symptoms, they're having an effect on me, and I need to seek support, what can you do? So I would say, first of all, have a think about what are the symptoms that are impacting you most severely? What challenges are they throwing up for you? And potentially, what would be the workable solutions within your role? So, what potentially could your employer offer that would help you in your daily role? And then seek a meeting with perhaps your line manager or perhaps part of your wellbeing team or your HR to have that conversation, not just around the challenges, but also what those potential solutions could be for you. Now, remember that you might be the first person to open that conversation about menopause symptoms. So, this might be the first time that your line manager has been in that situation. So give them the opportunity to hear you, to hear the potential solutions, and then go away and speak to their colleagues before having a follow-up where you can talk about what is workable. So what could potentially work for both of you. If you're somebody who is in the role of supporting another, if somebody does disclose to you, always ensure that you have their permission to share that information on, because that's important for confidentiality. It's also important that if this is the first time you've had that conversation, that you can then seek support from your colleagues too about what potentially could be involved in making some of those reasonable adjustments. And then make your colleague feel that your door is open and that the conversation can be ongoing. Because if you cast your mind back to that purple line going up and down on my graph, perimenopause to postmenopause is a transition. And that transition can bring change. So that can be change on a relatively regular basis. So any adjustments that you've made may need to be reviewed, perhaps on a 3-monthly basis. But just making your colleague know that they are supported in the workplace and that your door is always open to continuing that conversation will make the most huge difference. Without a doubt, the simple things are the ones that make the most difference. Kindness, compassion, and support. So we've talked a little bit about the workplace, but what about with our family and friends? Well, if none of us are ever given any education or information about menopause, we can certainly say that our partners, family, and friends don't receive that either. So when individuals start to experience menopause, often their loved ones feel completely unprepared. So it's really important where you can to let them know how you're feeling, to let them know how this transition is affecting you. And importantly, letting them know how they can help, because sometimes they feel completely at a loss, and other times they'll try to do the things that they think might help. And that's not necessarily what you need. So again, it's all about keeping those lines of communication firmly open. Now, some of the things that we regularly hear are the things that are the most helpful, whether it's in our work relationships or in our personal relationships, is having information. So everybody having some information, being acknowledged that this is happening and that this is something that can change, having ongoing understanding, having ongoing support, knowing that that support, that basis of support is there for you, knowing that it's not just you and that you're not alone, and kindness. That is probably the simplest of all of the things that makes a difference, is having kindness and compassion. So menopause and beyond. As we come to the end of the presentation, I just wanted to mention menopause and beyond, because for many people, their post-menopause will be 30 to 40 years of their lives, a significant amount of their lives. And unfortunately, over the decades, menopause has had a pretty negative narrative, when actually, if everybody had the right education and information, care and support before menopause came along, and they could make those informed decisions for themselves, or they get that care and support during that perimenopausal phase, then it does provide an opportunity to consider what you would like your future to look like. It's the perfect opportunity to review your lifestyle, your health, your nutrition, your exercise, and how you look after yourself. And more widely than that, it's also a good opportunity to look at things like personal and professional goals and ambitions. Now, they're all things that you can do when you do have the right help and support in place. And that's another reason why it's so important for that infrastructure to be there. So we've got, Chelsea, we were a few minutes late starting, so we've got about 15 minutes for questions if anybody has shared any questions in the chat, or if anybody would like to ask any questions. But before we go to that, if anybody would like to get in touch, you can find lots of our free resources, including things like the symptom checkers, the guide to getting the best out of your doctor's appointment. There's a guide for partners. There's lots of videos on the website with menopause specialists. We have a big menopause support Facebook group, around 33,000 we support there. You're very welcome to come and join. I have quite an unusual surname, so not difficult to find me on things like Instagram and LinkedIn. And we also have a podcast, and you'll find the link to that on the website too. So Chelsea, I'll stop sharing now, and then we can go to some questions if you have any.
Perfect. Thank you so much, Diane. Not sure if anyone has any questions that they'd like to send in now. I've also given you the option just to speak if you'd like to just ask a question from your mic. So it's completely up to yourselves.
Now, for some reason, Chelsea, this is now not giving me the option to, hang on, stop share. Yep, we're here. Got it. Marvelous. Yeah, so if there are any questions, please be aware there are absolutely no daft questions about menopause. Nobody ever teaches us anything about it. So all questions are very welcome. Chelsea, I think one of your colleagues has their hand up.
Sorry, yes, would you like to ask a question? Can you speak with your mic? Not sure if you're on mute. Or if you want to use the chat box, just send it in there. If you'd like to just send it into the Q&A box then instead, if you can't use your mic. Oh, brilliant. Thank you so much for saying that. And I think it's great that we have Diane here today just to answer some of our questions, kind of give us guidance as well. So I'm not sure if you could see that, Diane, but Gail just said not a question, but found this very interesting and ticked a lot of the boxes.
Oh, great, Gail. I'm glad it was helpful. Great. So just while we're waiting, Chelsea, just a couple of signposts for everybody. If you're looking for sort of good, reliable information, not just for menopause, but also for women's health, there's an excellent website called Women's Health Concern. It's the patient arm of the British Menopause Society. So you can rely on the information that's shared there because it is overseen, all of the information is prepared and overseen by the British Menopause Society Medical Advisory Committee. So that's a group of 20 menopause specialists who prepare the information for women's health concerns. So as well as information about menopause and HRT, you'll also find information there about things like PMDD, polycystic ovaries, endometriosis. So lots and lots of information there, not just for yourselves, but maybe for signposting to other people too. What I'll do, Chelsea, is I'll share a resources sheet with you that you can share with colleagues straight after the meeting. With things like some book recommendations and other websites. So things like the Daisy Network are an excellent website for those who are experiencing a premature menopause. They're dedicated to supporting those in premature menopause. So yeah, they're all places that we would sort of point people in the direction of, essentially.
Brilliant. And someone asked if we could share slides. We won't be sharing Diane's slides, but we do have this webinar recorded as a resource that we can use moving forward. So you can look back on it just to kind of refresh your memory, or if there's any kind of particular tips that you want to take on board as well. So we will be sharing this soon as a resource then. And as well, if people would like as well, I'd love to send out a form. So if there's any other questions you'd like to submit anonymously, that we can facilitate that. So I'll send out a form after this to everyone who was on the call today, and just to get your, your feedback, or if there's anything that you wanted to ask, but maybe you'd prefer not to ask it in this form. Not sure if anyone has any other questions. If not, we will leave it there. And Diane, thank you so much again for speaking with us today. We had a bit of technical difficulties at the start, but we got we got there in the end. So thank you so much. I really, really appreciate it. I know the team here appreciates it too.
Oh, my pleasure, Chelsea. Thank you so much for inviting me.
Brilliant. Thank you.